Before we dive in, a quick request. Please subscribe, like this episode, and drop your next community medicine topic in the comments. Your picks shape our lineup. Welcome back, everyone. Today's exam-ready episode is The Pathways of Disease, Modes of Transmission. We link the chain of infection to real-world control strategies you can write and use on postings. With us is community medicine specialist Dr. Joshi.
Happy to be here.
Dr. Joshi set the stage. What exactly do we mean by transmission, and why does understanding it matter even before the exact germ is known?
Transmission is the mechanism by which an infectious agent spreads from a source or reservoir to a susceptible person. The reservoir could be a person, animal, arthropod, plant, soil, or even a substance like water. Knowing the likely transmission route lets us propose immediate control, say safe water and hand hygiene for a suspected fecal-oral outbreak, long before the laboratory confirms the pathogen. For spread to occur, the agent must exit the infected host through feces, blood, respiratory secretions, skin lesions, and then reach a receptive portal of entry in the new host, respiratory tract, alimentary canal, urogenital tract, conjunctiva, or broken skin.
Great. Let's move through the classic categories. First up, direct transmission.
Direct transmission means immediate transfer without an intermediate vehicle. There are a few subtypes. 1. Direct physical contact, touching, biting, kissing, or sexual intercourse. Think sexually transmitted infections, HIV or AIDS, leprosy, and many skin or eye infections. 2. Droplet spread. Large respiratory droplets propelled by coughing, sneezing, singing, or even talking. These droplets typically travel about 1 meter or less before falling. They strike mucous membranes of the eyes, nose, or mouth. This is still considered direct transmission because the droplets do not remain suspended. 3. Direct inoculation or skin penetration. The agent is delivered straight into tissue. Examples include rabies virus through an infected animal bite, hepatitis B virus via contaminated needles, and hookworm larvae that directly penetrate skin when someone walks barefoot on contaminated soil. 4. Vertical transmission, parent to child, transplacentally, in utero, during delivery or through breastfeeding. Key examples are syphilis, hepatitis B, rubella, and HIV.
Quick case vignette 1. A sanitation worker sustains a needle stick injury while clearing biomedical waste. The source is unknown. What immediate steps would you emphasize?
First aid with soap and water, no squeezing. Report the exposure, assess risk, and follow your facility's post-exposure protocol. For blood-borne viruses, arrange baseline tests, consider hepatitis B immunoprophylaxis as indicated, and counsel on follow-up testing. Emphasize that this is direct inoculation transmission risk. Prevention hinges on safe sharps disposal and consistent personal protective equipment, spelled PPE.
Now to indirect transmission, the intermediary step.
Right, indirect routes involve a vehicle, air, or a vector. Vehicle-borne transmission uses contaminated inanimate materials, fomites, door handles, toys, soiled clothes, surgical instruments, passively carry agents. Ingestion routes include contaminated water, food, milk, or ice, leading to fecal-oral diseases like cholera, typhoid fever, hepatitis A, and poliomyelitis. Blood and tissue routes involve transfusion of infected blood or transplantation, tracically hepatitis B virus or HIV. This is why sterilization, asepsis, and blood safety are non-negotiable. Airborne transmission is distinct from droplet spread. Here, infectious particles travel through the air and remain suspended. The two forms are droplet nuclei, tiny particles roughly 1 to 10 micrometers, formed by evaporation of larger droplets that can stay aloft for long periods and reach alveoli, and dust, resuspended particles carrying dried secretions or excreta. Airborne diseases include tuberculosis, spoken as TB, measles, chickenpox, and Q fever. Control here means ventilation, respiratory protection, and where appropriate, airborne isolation rooms.
Vector-borne transmission uses a living carrier, commonly arthropods. Two broad types.
Mechanical transmission, the agent is simply carried on the vector's body. There is no multiplication or development. Houseflies contaminating food with diarrheal pathogens by soiling their feet is the classic example. Biological transmission, the agent multiplies and/or develops within the vector. This includes propagative multiplication only, like plague bacilli in the rat flea. Cyclodevelopmental, development without multiplication, like filarial worms in Culex mosquitoes or guinea worm embryos in cyclops. Cyclopropagative, both development and multiplication, like the malaria parasite in Anopheles mosquitoes.
Students often mix up droplet spread and airborne. Could you give a crisp comparator?
Absolutely. Droplet spread, short range, about 1 meter, heavy droplets fall quickly. Surgical masks and physical distancing reduce risk. Airborne, tiny droplet nuclei or dust remain suspended for long periods and travel farther. We need ventilation strategies and respiratory protection beyond simple distancing.
Let's tie transmission to epidemic patterns. How does route shape curves and clusters?
Two prototypes. Common source outbreaks like a contaminated water supply show a sudden rise and relatively rapid fall once the source is removed. Propagated outbreaks, person-to-person spread, show successive waves, a gradual rise and a prolonged, sometimes irregular decline. Many infections have mixed patterns. For example, hepatitis B virus can spread through blood, vehicle, and sexual contact direct, while Shigella spreads fecal-orally and person-to-person in close contact settings. Recognizing the pattern helps you decide whether to hunt for a shared exposure or strengthen contact tracing and isolation.
Case Vignette 2. A village fair ends with dozens of people developing acute watery diarrhea within 24 hours. The curve spikes, then declines after the public tap is chlorinated. What's your diagnosis of the transmission pattern and control measure?
That is a common source pattern, likely vehicle-borne through contaminated water or food. The control, water disinfection, targets the transmission route. For exams, remember, attack source, not just the agent.
Let's convert theory into control strategies. How do we break the chain?
Start with the most vulnerable link, the route of transmission. Some high-yield examples. For close contact and droplet spread diseases, hand hygiene, respiratory etiquette, masks in crowded indoor settings, early case detection and isolation when appropriate. In healthcare, add PPE and administrative controls to reduce exposure time. For airborne diseases, natural and mechanical ventilation, high-efficiency filtration where feasible, spacing in triage and respiratory protection for high-risk procedures. For water and foodborne diseases, safe water, source protection, filtration, chlorination, safe food handling, clean, cook, cover, cold chain, sanitation and hygiene education, and when indicated, chemoprophylaxis or vaccination. For blood and tissue safety, rigorous donor screening, serological and nucleic acid testing, sterile single-use syringes, and strict asepsis. For vector-borne diseases, integrated vector management, environmental measures like eliminating breeding sites, larval control, insecticide-treated nets, indoor residual spraying, protective clothing and personal repellents. Entomological surveillance guides which tools to deploy and when.
Can you give a quick memory scaffold that ties exit, route, and entry together for Viva?
Use ERE. E for exit from source, example feces, blood, droplets. R for route, example direct contact, droplet, inoculation, vehicle, airborne, vector, vertical. E for entry, example respiratory, gut, skin, urogenital, conjunctiva. Then state one barrier per route. For example, feces, water, food, gut. Barrier is safe water, sanitation and food hygiene. Blood, needle, tissue. Barrier is sterile syringes, safe sharps and PPE. Droplet nuclei, air, lungs. Barrier is ventilation and respiratory protection.
Quick self-checks for active recall?
Sure, pause and recall. What distinguishes droplet spread from airborne transmission? Name the three biological vector mechanisms, propagative, cyclodevelopmental, and cyclopropagative. Which epidemic curve pattern suggests a shared exposure? The answer is common source.
Any frequent pitfalls students should avoid in exams?
Two big ones. One, writing airborne when the question describes droplet spread. Remember the 1 meter rule and suspension time. Two, listing only agent-specific measures and forgetting route-based barriers.
Perfect. Wrap us up with a 1-minute takeaway, Dr. Joshi.
Classify routes as direct, contact, droplets, inoculation, vertical, or indirect, vehicle, airborne, vector. Recognize how routes shape epidemic patterns, then break the chain. Water and sanitation for fecal-oral spread, ventilation and masking for respiratory spread, safe injections and blood screening for bloodborne risks, integrated vector management for vectors, and maternal newborn measures for vertical transmission. If you remember ERE plus a barrier, you can act fast, protect communities, and earn full marks.
That's our time. If this helped your revision, hit subscribe, like the episode, and tell us what to cover next. See you soon.